Hello, my name is Dr. Hamilton. I'm a PGY3 resident at South Shore University Hospital, Family Medicine Residency Program in Bayshore, New York. My co-author for this presentation is Dr. Xian Li from Go Health Urgent Care. The title of my presentation is Management of the Patient with Epixtaxis. I have nothing to disclose. Epistaxis, also known as nosebleed, is a common ENT complaint seen in the outpatient setting. A conservative approach is a first-line treatment, and other methods are usually used if bleeding does not resolve. In the United States, the prevalence is 60%, 10% or less seek medical care, and approximately 10% require ENT referral. A bimodal age distribution is seen with the majority younger than 10 or between ages 45 and 65. Males are at relatively higher risk than females. Most epistaxis is anterior in origin due to the rich blood supply of the nasal septum, specifically the Kisselback plexus. Less common are posterior bleeds, which arise from branches of the spinal-palatine arteries. The three most common causes of epistaxis are 1. Epistaxis digitorum, also known as nose picking, 2. Low moisture or humid hair, and 3. Mucosal hyperemia. Classification of epistaxis include 1. Local causes, such as rhinitis, trauma, septal deviation or perforation, foreign bodies, irritants, or intranasal polyps. 2. Systemic causes, such as bleeding disorders, hypertension, medications, vascular condition, malignancy, alcohol use, heart failure, platelet dysfunction, or liver disease. The initial evaluation of a patient with epistaxis should involve the assessment of airway, breathing, and circulation. A thorough examination of the nose and oropharynx should also be done. The history of the presenting illness should also be done, which includes the timing, frequency, precipitating factors, trauma, prior episodes, and bleeding at other locations. Additionally, the past medical history should be taken, medications, family history, social history, and the use of illicit drugs such as cocaine or chronic alcohol use and living conditions. The treatment approach for epistaxis can be seen in the algorithm shown in Figure 1. Initial assessment should involve assessing the airway, the breathing, and the circulation. Any abnormalities require resuscitation as needed, and ENT or surgery should be referred as required. The first step is the use of conservative methods, such as the use of a compressive therapy and oxymetolazone, also known as Afrin. Compressive therapy involves the use of the Trotter's method, in which pressure is applied to the alley of the nose, and while the patient sits and leans forward to prevent complications such as aspiration. Additionally, a nasal compressive device can be created by using a tongue compressor in order to apply pressure to the nasal alley in order to prevent further episodes of epistaxis. If this fails, the next step is the use of cotton soaked in Afrin, which is then applied to the nostril. Additionally, epinephrine at a 1 to 1,000 dilution can also be applied to the nostril. If bleeding resolves, the patient should be observed for rebleeding and instructed to follow up with PCP or ENT as needed. If bleeding continues, the nose should be examined to determine the source of the bleeding. If the bleeding is anterior or posterior in origin. For posterior bleeds, it's recommended that it should be used the balloon catheter or Foley catheter for the nasal packing. If either method fails, ENT should be referred to in order to perform an endoscopic artery ligation, which is the preferred method, or endovascular embolization. If the source of the bleeding is anterior in origin, direct therapy using silver nitrate or electrical desiccation cautery should be used. If either methods are unsuccessful, nasal tampon or packing with or without TXA or topical antibiotics should be done. Additionally, the use of anterior balloon or gauze can be done if the use of nasal packing becomes unsuccessful. If bleeding continues, bilateral nasal packing should be done and patient should be referred to ENT or surgery as needed. Treatment failures of epistaxis include the inability to stop bleeding, and in the event, ENT referral or surgery may be required due to the bleeding persisting. Common surgical procedures are endoscopic ligation and angiographic embolization. Complications of epistaxis include aspiration, intranasal adhesions, and hypovolemia. Complications associated with nasal packing include pressure necrosis, septal hematoma or abscess, and sinusitis. It is important to inform your patient of follow-up information and also preventative measures to prevent further episodes. ENT should be referred if bleeding occurs within the next 24 to 48 hours after an initial episode. Also, consider ENT referral if acute anterior epistaxis worsens and require bilateral nasal packing. Patients with uncomplicated anterior nosebleed should be encouraged to use a humidifier while sleeping. Also, patients should be encouraged to avoid medications that induce bleeding, such as chronic alcohol use and the use of illicit drugs such as cocaine. Patients can also be instructed to apply topical antibiotics such as mupirocin and Bactroban to nasal mucosa to prevent further nosebleeds. Lastly, it is important for patients to treat the underlying medical condition in order to prevent further epistaxis episodes. As mentioned earlier, one of the causes of epistaxis is systemic causes such as bleeding disorders, hypertension, alcohol use, etc. By treating the particular medical condition that is a cause of the epistaxis, patient can prevent further episodes from happening. Discussion and conclusion. Epistaxis is a common presentation in the outpatient setting. It is important to understand the anatomy and blood supply of the nose and have a broad knowledge of the management to prevent further medical emergency. For most patients, conservative management is adequate for control and most are self-limiting. However, education should be readily available to patients who are prone to nosebleeds, and adequate teaching should be given in the event the patient experiences a nosebleed. Advancement in the management of epistaxis have allowed patients to easily manage in the outpatient setting and are sent to the hospital if they have significant comorbid conditions or complications from blood loss. It is important to mention the clinical recommendations associated with epistaxis management. A grade C evidence rating is compressive therapy should be the first intervention to stop anterior epistaxis. Another grade C evidence is silver nitrate and electrical desiccations are effective at stopping anterior epistaxis in patients when compressive therapy is unsuccessful. A B evidence is, when available, endoscopic artery ligation may be the best initial treatment for posterior epistaxis because it is more effective than packing and less costly than endovascular embolization. In general, as primary care providers and providers in the outpatient settings, we should be aware of the management of epistaxis and be able to perform basic conservative methods and to be aware of when to refer the patient to the emergency room or surgery/ENT for further evaluation. That is the end of my presentation, and thank you for listening.